Good morning, colleagues. We are here to navigate the complex architecture of antimicrobial stewardship programs. In an era where multi-drug-resistant organisms, specifically the escape group and NDM1 producers, threaten the very foundation of modern medicine, stewardship is no longer optional. It is a clinical and ethical mandate. Today, we will examine how the global standards set by the WHO and CDC are being translated into actionable, high-impact frameworks within the Indian healthcare ecosystem, specifically looking at the national directives of the ICMR and pioneering state action plans. Slide 2. The core directive, precision via the 4 Ds. The primary goal of any AMSP is to unlock the core directive of clinical precision, delivering the right drug for the right bug. This is operationalized through the 4 Ds framework, selecting the right drug based on targeted microbiological evidence, ensuring the right dose to optimize concentration-dependent or time-dependent killing, maintaining the right dosing interval to balance efficacy against potential toxicity, and prescribing the right duration to minimize the selective pressure that drives resistance. By strictly adhering to these pillars, we maximize patient outcomes while safeguarding our most precious medical resources. Slide 3. The Framework Alignment Matrix. When we compare international and national standards, we see a unified front. The CDC's 7 core elements, leadership commitment, accountability, pharmacy expertise, action, tracking, reporting, and education, form the global backbone. These are perfectly mirrored in the WHO Global LMIC Standards and the ICMR National Action Plan. Key requirements across all frameworks include the appointment of a dedicated infection control officer, ICO, often a clinical microbiologist, and a co-leader with pharmacy/drug expertise to drive implementation at the bedside. Slide 4. Navigating the maturity staircase. Recognizing that resource levels vary, the WHO proposes a maturity staircase for implementation. Basic level focuses on foundational steps like adopting prescription-only policies and integrating the WHO AWARE classification, Access, Watch, Reserve, into national essential medicine lists. Intermediate level moves toward diagnostic stewardship, promoting adherence to evidence-based guidelines for common syndromes like CAP and UTIs. Advanced level involves formal programs with trained staff who track antibiotic dispensing data to set national improvement targets and actively address drivers of inappropriate prescribing. Slide 5. India's National Mandates, ICMR. The Indian Council of Medical Research, ICMR, has tailored global policies into 4 actionable national mandates. Structural mandates require the formation of multidisciplinary teams and local standard treatment guidelines, STGs. Prescribing controls introduce the Adult Inpatient Antibiotic Approval Form, requiring clinicians to justify the use of restricted or reserved agents. Clinical interventions and strong surveillance ensure that these policies are not just static documents, but living processes monitored through regular audits. H3. Slide 6. Regional execution, the Indian state action plans. India's regional response demonstrates diverse strategic identities. First, Kerala, KARSAP. Distinguished by its strong One Health response, Kerala has established a state coordinating center for surveillance that encompasses human, animal, and environmental sectors, supported by strong public-private partnerships. 2. Delhi SAP-CARD focuses on a strong regulatory and urban approach, specifically targeting the over-the-counter OTC sale of Schedule H1 antibiotics and integrating stewardship into community-level Mohalla clinics. Madhya Pradesh, MP-SAPCAR, emphasizes an academic and institutional identity, establishing a centralized resource center for tropical and infectious diseases at IIMS Bhopal to lead research and innovation. H3. Slide 7. Core clinical operations. The engine of an AMSP consists of 4 high-leverage operations. Prospective audit and feedback involves the real-time review of prescriptions by the stewardship team to streamline therapy. Formulary restriction and pre-authorization controls access to high-end antibiotics like carbapenems or colistin to prevent their misuse. De-escalation, streamlining, is the vital transition from broad empiric therapy to narrow-spectrum agents once culture results are verified. Finally, the IV to oral switch is prioritized to reduce hospital stay and the risks associated with invasive catheters. Slide 8. The 48-hour clinical pathway, the timeout. To operationalize these interventions, we utilize the antibiotic timeout concept. Day 0. Empiric treatment begins based on clinical suspicion and local antibiograms. Day 2. This is the critical juncture. Once microbiology results return, the clinician must perform a scheduled reassessment to either de-escalate, switch to oral therapy, or stop the drug if no infection is found. Day 5 to 7. The final phase focuses on ensuring the total duration is optimized, preventing the unnecessary prolongation of therapy that leads to resistance and toxicity. Slide 9. The monitoring and evaluation dashboard. We measure success through a balanced dashboard. Process indicators track volume using the defined daily dose per 1,000 patient days and adherence to surgical prophylaxis timing within 60 minutes of incision. Outcome indicators assess the clinical impact, measuring reductions in C. difficile and HAI rates. We also include balancing measures like 30-day readmission and mortality rates to ensure that restricting antibiotics does not inadvertently harm patient safety. Slide 10. The twin engines, AMSP plus IPC. Stewardship does not exist in isolation. It is one of the twin engines of AMR containment, working in total synergy with infection prevention and control. While AMSP focuses on protecting the drug by reducing selective pressure, IPC focuses on preventing the bug by stopping cross-transmission via hand hygiene, PPE, and care bundles. Their shared objective is the preservation of limited healthcare resources and the reduction of morbidity and mortality. Slide 11. Conclusion. The ecosystem approach. In conclusion, the ecosystem approach pioneered in Kerala serves as a roadmap for success in LMICs. This model relies on a pyramid of formal coordination between central and state governments, a robust state strategy of intersectoral collaboration, and informal networks for community-level knowledge exchange. True impact is achieved only when human health, animal health, and policy regulation operate from a unified strategic blueprint. Thank you for your attention. I am now happy to address any questions.